Thank you for joining us. We're here in Boston at Myeloma 2014, and we've just finished our first day of the meeting, which was a very stimulating day, and we're going to cover a couple of things we talked about during the sessions. I'm joined, my name is Keith Stewart, I'm a hematologist at the Mayo Clinic in Scottsdale, Arizona, and I'm joined by, I'll have everybody introduce themselves.
My name's Gareth Morgan, I'm a hematologist in London.
Leif Bergsagel, also a hematologist at the Mayo Clinic in Arizona.
And Antonio Palumbo, hematologist from Torino, Italy.
Welcome. Gareth, we started the day talking about the genome in myeloma and what we found. Can you very quickly summarize for the viewers what the conclusions were, the take-home points?
It's a really exciting time for studying the genome of myeloma, and I think now there's probably 670 patients that have had their genome sequenced. We know the commonly mutated genes, we know they belong to specific families, and we're beginning to understand what are the really prognostic events for patients. And so within a short time we'll be able to use this information to direct treatment.
Dr. Bergsagel, what do you think were the clinical implications of the findings today?
I think it was a bit sobering, the fact that there are so many different subclones of the tumor, and that targeted therapy that targets only one part of the subclone won't be effective for a long time. And so there was a lot of talk about different strategies to deal with that, using combinations, using immunotherapy, but ways to approach that. I think it was the most sobering aspect of the discussion.
Dr. Palumbo, what would you say was your take-home clinical message based on what we now understand about all the different clones that are in myeloma, how they come and go, they mutate over time? What do you think that means to us as treating physicians?
Well, certainly I would say we are moving from the old-fashioned test looking at chromosome abnormalities, translocation, to a more sensitive possibilities of looking at genetic mutations and see how those may change from diagnosis to relapse, and how they might change from one treatment to the other. So today we certainly have a much more powerful tool to define the sensitivity to a drug, the resistance, the prognosis, as has been mentioned before. So now I think in the near future, the goal is to define which is the relevant mutation, which is the mutation that is driven by a given treatment, and therefore move to a more specific and personalized treatment approach.
And one of those personalized treatment, probably the main one that came from sequencing, was the identification of mutation in Raph in about 5% of patients. And Dr. Morgan, you've had some experience with Raph inhibitors in myeloma. What have you found, and what's your advice going forward?
So I think it's staggering. Heavily chemo-treated, aggressive, disseminated disease that carries a mutation in a significant proportion of the cells. You switch off the activity of that molecule with a drug, and patients will go into a response. So it tells you that the cell is so messed up that if you switch off just one thing, that you can get a remission. The challenge, though, kind of building on what Leif says, is how do you keep people in a remission once you've induced it with these agents? And I think what we're in the process of working out are strategies to do that.
Thank you. You know, in our second session today, we moved on to talking about how early we should treat patients, and that's prognostically relevant because presumably the earlier we treat, the less of this genomic chaos that is present. But there was some debate about whether it was okay to use one or two drugs, or whether one needed combination therapies to try and kill all the clones. So maybe Leif, I'll ask you what your opinion is on, should we treat myeloma earlier? And if so, should we do it with one or two drugs or combinations?
Yeah, no, it was a really exciting day because we heard about two approaches to treat myeloma early. One has been published in the New England Journal using Revlimid and dexamethasone, and with very good outcome with minimal oral therapy that's easy for patients to take. And then we heard about results from Ola Landgren using carfilzomib, lenalidomide, and dexamethasone, where he had 100% response rates, and almost all the patients had minimally no detectable disease. And he commented, though, that with 8 months of therapy, where patients have to come in 2 weeks and 2 days a week for 2 weeks out of 3 was really disruptive for the patient's life. And I think that if we are to treat myeloma, that we should probably treat it the most effective way that we know. So I would argue for doing or exploring further the kind of things that Ola Landgren has done.
And that might get easier as we get
As we
oral
get
drugs.
That's right.
I mean, it was astonishing. 12 of 12 patients had or 11 of 12 had a deep, complete remission when treated early. It was quite astonishing. What's your opinion on it? Would you go home and start treating your myeloma patients earlier now, Dr. Palumbo?
I think absolutely yes. There is a need to change all the CRAB criteria that we have been using since now more than
By
almost
CRAB
5 to
criteria, you
10.
mean hypercalcemia, renal
Yeah,
failure?
today the paradigm is we start treatment when there is organ damage done by bone lesions or anemia or renal insufficiency or hypercalcemia. I think we should probably move to a better definition of early myeloma when the bone lesion can be detected with MRI and not only X-ray. When we start to have a major bone marrow infiltration, when we start to have a M component doubling in a very short period of time, I think we should probably start treating in those conditions. And the reason to start an early treatment is because, no question, early on the disease is much more sensitive than later. More you wait, more the disease becomes more resistant, and therefore the efficacy of the treatment is getting lower and lower. So I think there is a major message coming that an earlier treatment is needed, especially with the new imaging opportunities we do have. And I think this is essential to increase the treatment efficacy. Then the discussion will be, should we use a two-drug approach, a more complex approach? And this is certainly the ongoing discussion.
And that's the research topic of one of them anyway. The other piece of the puzzle, I think, was a little bit of a debate about whether precision therapy was really that important or whether one should just target the biology of the plasma cell, arguing that the drugs we use today mostly and are successful mostly target biology rather than specific genetic mutations. So what do you think about that, Gareth?
So it's clearly one is not exclusive from the other. I think that's the only conclusion you could come to. If you can target the biology, target it. If you can target the tumor, target it.
But not apart, right?
Yeah, you can do them both together. I mean, it's silly to focus on one. The aim is to just generate as many therapeutic options as we have and then try and use them in the most sensible way. I mean, that's what precision medicine is. It's what the concept involves. Use a diagnostic test, use your clinical acumen, pick the right drug for that patient.
After lunch today, we moved on to a new type of therapy which is agnostic to the tumor genome, which is immunotherapy, which is, of course, having a resurgence in myeloma care. So do you want to summarize what you heard today and what you think the promise of this is, Dr. Bergsagel?
Yeah, we heard some really exciting things, and it does. The great thing about immunotherapy is that it can target all the different subclones that may be there. And we heard about T-cell therapy in particular, using CARs, which have a chimeric antigen receptor that can recognize different antigens on the plasma cells. And they've worked brilliantly in leukemia that expresses CD19. And we've heard that is going to be tried in multiple myeloma. But we really think a lot of the promise is going to be on CARs that are specifically developed for myeloma, targeting antigens like BCMA that are only on the myeloma cells. And we heard about some other approaches looking at other ways of modifying or activating T cells where they are using tumor-infiltrating lymphocytes that are expanded ex vivo and given back to the patients. And there's a real promise, I think, that these will be approaches that will be able to give long-term disease control.
Dr. Palumbo, do you share that optimism, or do you think the immune system's too decrepit in myeloma?
Well, no, I absolutely agree with his comment because basically I think the major breakthrough, possibly breakthrough for the future, will be the use of the antibodies. We have been using these novel agents, and the outcome has been almost, and the survival between double or triplicate in relation to 10, basically even 10 years ago. So we already have a major survival improvement. Now the next step is certainly the antibody. The antibody gives us the opportunity to probably have at least another the improvement in terms of the treatment efficacy of, again, doubling what is the survival of today. The plus, beside the antibody, is the ability to really activate the T cell system, and at that point this might probably change completely the disease, because at that point the control could be really sustained, and we are not talking about cure, of course, but certainly if we will be able not only to have a specific target with an antibody, but also to have a T cell capacity to keep it and have memory over time, this might definitely change the prognosis.
You mentioned the cure word, and that was discussed today, and I think there was some variable opinion, but certainly there was a sense that there may be some patients who certainly are in a long-term remission bordering on cure, if not cure itself. What was your impression of that discussion?
So I think it's where we are in the community. I think we need to consider cure because it informs your treatment approaches. It means you use more combinations. It means you intensify your treatment up front, and I don't mean by intensifying in intensive chemo, I mean like adding more antibodies in, using your best treatments in combination. And I think it's panning out for younger, fitter patients in a remission after an autograft that go on to have, some maintenance strategies or post-transplant consolidation. You can expect a significant proportion to be alive and well at 10 years. And we heard from Dr. Balaghi that if you get to 10 years, the curves start to flatten out. So I think we're seeing significant proportions of patients alive and well at 10 years, and we should be optimistic with new drugs coming along as well, that we can get more and more people into that status.
Thank you. We finished the day with my favorite session, which was looking at the class of drugs, thalidomide, lenalidomide, and pomalidomide, or what were called the IMiD drugs, and how they work. And I thought the science was just beautiful that was presented. So anybody want to comment? I'll just throw open what your take-homes from that session were.
So I'm kind of completely blown away by it as well, to kind of know what a drug binds to, then to understand.
A single amino acid.
Yeah. And then it changes the downstream profile of the cell that leads to that cell dying if it's a B cell, a tumor cell, and then the converse, the T cells overexpress IL-2, get more active and kill the tumor. It's absolutely amazing.
And for those of you who don't know what we're talking about, these drugs all turn out to bind a protein called cereblon in myeloma, and probably in some lymphoma cells too, which is the key to their activity, and they degrade some proteins which are necessary for myeloma cell survival. Very elegant work. And Leif or Antonio, do you want to comment on those last session?
I think it's amazing that for 50 years we haven't known really how these drugs have worked, and we've just had empirically used them. And I think now that we understand it, and I think there's a lot of confidence that this is really the mechanism and that this is how they work, we'll be able, I think, one, to use them in a better fashion and to understand how they work with the other drugs we use. And we heard about perhaps isolating or selecting better ones that more specifically will hit myeloma and not have some of the bad effects that we see with the IMiD drugs. So I think it was also my favorite session today, and a real eye-opener.
And we heard, of course, from one of our sponsor companies that they have a new version of these drugs which looks incredibly potent, not just in myeloma, but in liver cancer and in lymphoma. Really exciting stuff to come. Any closing comments, gentlemen? Anything we haven't covered that you'd like to comment on, or just give us an overall sense of where you think myeloma is heading?
I think kind of one thing that these meetings do illustrate is, one, it's always good to see your friends who work in the same area, but if you really take science and apply it to study a disease in a focused fashion, you get answers and you can improve patient outcomes. And I'm always struck by that after this meeting.
Well, that's, oh, sorry, Leif.
I was just going to say, I'm amazed at how much has happened since we had this meeting, which I don't know how, was it a year ago or just over? There's so much new stuff that's being presented here that really speaks to the rapidity with which we're making advances.
Yeah, I completely agree with what he just said. In 1 year, you can see so many new things happening, so I think the improvement is really running faster and faster year after year. That was my major impression.
It's been a very good day. We've got more to come tomorrow. It wouldn't be possible without our sponsors. Our sponsors for this meeting were Celgene Corporation, Millennium, the Takeda Oncology Company, Bristol Myers Squibb, Janssen and Sanofi Aventis, as well as Onyx Pharmaceuticals. So we want to thank their support of the meeting, without which we couldn't get together and just see these dramatic developments and discuss how they're going to impact and change and improve patient care. So thank you for your attention.